Hello friends, welcome to my channel. Today we are going to discuss drugs acting on renin angiotensin system. These drugs falls under the classification of antihypertensive drugs. In this topic we are going to discuss on renin angiotensinogen, types of RAAS system, pre-prorenin receptors, adverse action of angiotensin 2, drug classification like drugs acting on angiotensin converting enzyme inhibitors, drugs acting on angiotensin 2, renin antagonist, adverse effects, drug interactions, and pharmacokinetics of these drugs. Renin is produced from the juxtaglomerular apparatus of the kidney. Angiotensinogen is produced from the liver, and angiotensin converting enzyme is produced from the epithelial cells of the lungs. Renin is a proteolytic enzyme. It is secreted from the juxtaglomerular apparatus of the kidney. Let's see the parts of the juxtaglomerular apparatus. This apparatus consists of two arterioles. One is afferent arteriole and second one is efferent arteriole. These afferent arterioles consist of specialized cells called as granular cells. From these granular cells, renin will be produced. Let's see factors that stimulate the production of renin. Sodium chloride loss, fall in blood pressure, fall in blood volume, and renal ischemia. All these factors will trigger low macular densa sodium and chloride ions, low glomerular efferent pressure, and enhanced sympathetic activity. Let's see what is macula densa. Inside of the distal tube of nephron consists of specialized cells called as macula densa. It will sense the low sodium concentration. So whenever sodium concentration is less, then macula densa will be activated to produce renin. Let's discuss types of renin angiotensinogen systems. The first one is circulating renin angiotensin system. Liver produces. Our second main character of this topic is angiotensinogen. This is a plasma alpha 2 globulin. As the renin is a proteolytic enzyme, it will convert the angiotensinogen into angiotensin 1. Angiotensin 1 is a decapeptide. Next, here comes our third main character of this topic is angiotensin converting enzyme. This will produce from the endothelium of the lungs. Angiotensin converting enzyme converts the angiotensin 1 into angiotensin 2. Angiotensin 2 is a octopeptide. This is a potent vasoconstrictor. The T off of this angiotensin 2 is 15 minutes. This angiotensin 2 will be converted into angiotensin 3 due to aminopeptidase. Angiotensin 3 is a heptapeptide. Again, this angiotensin 3 will be converted into angiotensin 4 by the aminopeptidase. Angiotensin 4 is a hexapeptide. Both angiotensin 3 and angiotensin 4 both will be inactivated by angiotensinase enzyme. Angiotensin 3 stimulate the production of aldosterone secretion. Angiotensin 2 elicit its action through two receptors, that is angiotensin 1 and angiotensin 2. These both receptors category of G protein coupled receptors. Angiotensin 2 is limiting factor for renin production. Angiotensin 2 causes the vasoconstriction, sodium water retention, and aldosterone secretion. Due to vasoconstriction, the blood pressure will be raised, and due to sodium water retention, the blood volume will be going to raise. Due to this rise in blood pressure and increased blood volume, antagonize the production of renin. Friends, I am going to repeat again. Renin is a proteolytic enzyme secreted from the juxtaglomerular apparatus of the nephron. This juxtaglomerular apparatus consists of the afferent arteriole and efferent arteriole. Afferent arteriole consists of granular cells. This will produce the renin enzyme. Factors that stimulate the production of renin are sodium chloride loss, fall in blood pressure, fall in blood volume, and renal ischemia. All these factors triggers the low macular densa sodium chloride, low glomerular afferent pressure, and enhanced sympathetic activity. Let's see the macula densa is inside of the distal tubule of the nephron. There are some specialized cells called as macula densa. It will sense the low sodium concentration. So whenever sodium concentration is less, then macula densa will be activated to produce the renin enzyme. When coming to the circulating renin angiotensin system, liver produces the angiotensinogen. This is plasma alpha 2 globulin. Due to renin, this angiotensinogen converts into the angiotensin 1. It is a decapeptide. Angiotensin converting enzyme will be produced from the endothelium of the lungs. This angiotensin converting enzyme will convert the angiotensin 1 into angiotensin 2. This is the octapeptide. Angiotensin 2 is a potent vasoconstrictor. The T-half is the 15 minutes. Due to aminopeptidase, angiotensin 2 will be converted into angiotensin 3. Angiotensin 3 is a heptapeptide. Again, due to aminopeptidase, angiotensin 3 will be converted into angiotensin 4. Angiotensin 3 and angiotensin 4 will be inactivated by angiotensinase enzyme. This angiotensin 3 stimulates the production of aldosterone secretions. Angiotensin 2 elicits its action through angiotensin 1 and angiotensin 2 receptors. These both receptors belongs to the G protein coupled receptors. Now coming to the types of renin angiotensin systems. First one is circulating renin angiotensin system and second one is local renin angiotensin system. Again in local there are two types are there. One is extrinsic and the second one is intrinsic. Now coming to the local renin angiotensin system. First one is extrinsic. Blood vessels capture the circulating angiotensinogen and renin to produce angiotensin 2 on their surface to produce the local action. And second one is intrinsic. Tissues like heart, blood vessels, brain, kidney, and adrenals possess the capacity of synthesis of RAAS within their cells to regulate organ function, cell growth, apoptosis, remodeling, and fibrosis. Coming to renin-prorenin receptors. In the kidney, juxtaglomerular apparatus produces the renin enzyme. The other tissues which are expressing local renin angiotensin system will produce preprorenin. This produces in large quantities than renin, like 5 to 10 times more than renin enzyme. The activation of prorenin takes place two types. One is non-enzymatic. This is a reversible action. And second one is enzymatic. This is a non-reversible action. Coming to enzymatic activation, proconvertase 1 or cathepsin converts the prorenin into renin by cleaving of hindering propeptide and catalytic domain of the renin is exposed. Then coming to the non-enzymatic activation, when prorenin attaches to prorenin receptors, these receptors expressed in heart, blood vessels, kidney, brain, eye and liver. So then conformational changes is happened in prorenin. So propeptide segment will be unfolded. So then catalytic domain of the renin will be exposed. When renin and prorenin receptors combined, the catalytic activity of renin is augmented several folds. This prorenin exerts its effects via two pathways. One is angiotensin 2 dependent pathway and second one is angiotensin 2 independent pathway. Coming to the first one, angiotensin 2 dependent pathway. Prorenin or renin, when they activated, angiotensin 1 will be produced due to angiotensin converting enzyme. Angiotensin 1 will be converted into angiotensin 2. This angiotensin 2 acts on angiotensin 1 and angiotensin 2 receptors and tissues to produce the effects of cell growth, inflammation and apoptosis. Then coming to angiotensin 2 independent pathway, when prorenin or renin attached to prorenin receptors of the cell surface will directly triggers intracellular signals via activation of MAP kinase, plasminogen activator inhibitor, transcription factors, JAK-STAT pathway and proto-oncogenes. All these causes the again cell growth, inflammation and apoptosis. The overactivity of renin angiotensin system, this is very important friends, causes the pathological changes and end organ damage, ventricular hypertrophy, congestive heart failure, nephropathy and retinopathy. The ratio of circulating prorenin and renin, if this ratio is elevates in the diabetes, will causes the nephropathy and retinopathy. Now let's discuss actions of angiotensin 2. First one is cardiovascular system. As the angiotensin 2 is a potent vasoconstrictor, it will causes the vasoconstriction. So it will leads to hypertension, increase the force of myocardial contraction by promoting calcium ions influx, and increases the heart rate by enhancing sympathetic activity, and in chronic basis it will leads to hypertrophy, hyperplasia and increases the intracellular matrix production. And coming to effects on kidney and adrenal cortex. Adrenal cortex enhances the synthesis of aldosterone. This will act on distal tubule, so it leads to sodium ion reabsorption, potassium and hydrogen ions excretion, and these effects are exerted at the concentration lower than those required to causes the vasoconstriction. And coming to the kidney, angiotensin 2 promotes the sodium and hydrogen ion exchange in proximal tubule of nephron, increases the sodium, chloride and bicarbonate ions reabsorption, and decreases the renal blood flow and glomerular filtration rate and produces intrarenal hemodynamics effects. Again, this will lead to sodium and water retention in the body. This will causes the hypertension. Coming to the central nervous system, angiotensin 2 induces drinking behavior and ADH release. Friends, what is the ADH? Please write in the comments. This ADH causes the plasma volume expansion, increases the central sympathetic flow. This will lead to contribute to pressure response. Let's discuss drug classification of inhibitors of renin angiotensin system. As we discussed earlier, angiotensin converting enzyme inhibitors. This enzyme, if we blocks, angiotensin 2 will not be formed. So once vasoconstriction we can stop. Second one is angiotensin receptor blockers or angiotensin 2 blockers. Third one is aldosterone blockers. Fourth one is renin antagonist. If we resist the renin, angiotensin 2 will not be formed. And fifth one is sympathetic blockers. As the sympathetic activity will activates the production, so block the sympathetic blockers. Direct renin inhibitors. This is the rate limiting step. Angiotensin converting enzymes or AC inhibitors. Angiotensin receptor blockers and aldosterone antagonist. Angiotensin converting enzyme inhibitors or AC inhibitors. The name of these drugs end with pril suffix. Also, angiotensin receptor blockers ends with sartans. Coming to the AC inhibitors, these are prils. Example, Captopril, Enalapril, Lisinopril, Benazpril, Ramipril, Fosinopril and Perindopril. This except Ramipril, all drugs are prodrugs. Ramipril is only active form. Except lisinopril, remaining drugs will be affected by food. So they should be taken 1 hour before food or after food. The important point is angiotensin converting enzyme is non-specific enzyme. So AC inhibitors splits of dipeptidyl segment from several peptides includes bradykinins, substance P, natural stem cell regulating peptide and enkephalin. So bradykinins accumulates airways and causes the dry cough. So dry cough is a common side effect with drugs. First one is Captopril. It is a prodrug. In the presence of food, decreases the bioavailability. So it should be taken before 1 hour food or after 1 hour food. Adverse effects are hypotension and hyperkalemia. Friends, please comment in the comment section what is hyperkalemia. Hyperkalemia is observed in the patients with impaired renal function and patients those are taking potassium sparing diuretics, NSAIDs and beta blockers. Dry cough, rashes, urticaria, dysgeusia. Friends, what is dysgeusia? Please write in the comments. It is a very rare and reversible. Fetopathic. AC inhibitors must stop when women pregnant. It will causes the decreased fetal growth, growth retardation, fetal death. Granulocytopenia and proteinuria. This is very rare. Acute renal failure. Patients with bilateral stenosis due to fall in glomerular filtration rate pressure. Antacids, when combined, decreases the bioavailability of these drugs. Lithium ion clearance will be decreases, so toxicity may occur. Patients who receiving angiotensin converting enzyme inhibitors with diuretics, when they given NSAIDs, attenuated hypotensive action by retarding salt and water. Renal failure is reported when these drugs given to patients, mainly elderly, receiving angiotensin converting enzyme inhibitors plus diuretics. Let's discuss about angiotensin blockers or angiotensin receptor blockers. The name of these drugs end with the sartans. Examples are Losartan, Valsartan, Telmisartan, Olmesartan, Candesartan, Irbesartan. Valsartan, food interfere its absorption, so it should not taken immediately before or after food. Telmisartan, dose should be reduced in patients with liver disease. Olmesartan, it's a prodrug and dose adjustment is not required in liver or kidney disease. Coming to the Losartan, less bioavailability due to first pass metabolism, no effect of food in absorption, dose should be reduced in hepatic dysfunction. Coming to the adverse effects are hypertension and hyperkalemia. Few patients reports of dry cough, but these drugs free from dry cough and dysgeusia. Angioedema reported in some patients. Headache, dizziness, weakness and upper GI irritation are mild and occasional. Fetopathic potential is observed as like as ACE inhibitors, so these drugs should not be taken during the pregnancy. Mild proboscis like uricosuric action is produced. Then coming to the renin inhibitors, example is Aliskiren. The mechanism of action of this drug is it binds to the catalytic site of renin and competitively blocks the access of angiotensinogen. Coming to adverse effects are it is contradict during the pregnancy, dyspepsia, abdominal pain and loose stools, headache, dizziness, hyperkalemia, cough, angioedema, hypotension and rashes. These effects are less than that of ACE inhibitors. So that's it friends for this video. In the next video I am going to discuss all the drugs classifications of antihypertensive drugs. If you like this video, please like, share and subscribe my YouTube channel. Thank you. See you soon.